Good afternoon, good morning, and welcome everyone to today's webinar, LaVera Crawley and Kelsey White, titled Racial Differences in Spiritual Care, Existing Evidence and Future Research. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. The response to this webinar has been amazing. As of this morning, we have just shy of 600 registrants. I just want to take a moment at the top here to thank our good friends and co-sponsor for this event, the Chaplaincy Innovation Lab. You can learn more about the network at their website, chaplaincyinnovation.org. Just some housekeeping instructions. You are listening in using your computer speaker system by default and are muted. You'll have the opportunities to submit text questions to our guests by typing your questions into the questions pane of the control panel that's located at the side of your screen. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. And with that, I'd like to introduce Dr. George Fitchett, Executive Director of Transforming Chaplaincy.
Thanks, Andy. Welcome, friends. Glad to have you all with us for today's webinar. Andy, let's look at the next slide. I want to provide a little background as we get started here. The events of the past year, including the murder of George Floyd last spring, have raised our awareness about systemic racism in our society. And the disproportionate toll of COVID-19 on people of color has especially raised our awareness of the harmful effects of racism on health. As we look at racial disparities in health and health care, Transforming Chaplaincy colleagues have had several conversations about whether there are racial disparities in spiritual care in health care. As we gave voice to that question, I realized there were several existing studies that had information about it. I suggested that we take a look at those studies and at what they do and do not tell us about the guiding question for today's webinar. Are there racial disparities in who receives spiritual care? In today's webinar, we'll begin by taking a look at 4 existing research studies. We'll discuss what they do and don't tell us about the guiding question, and then we'll talk about next steps for research about this question. It's important to underscore that we want you to think of today's webinar as the beginning of a conversation about the question. The research that exists about the question is very limited, and much more needs to be done. But we hope that this conversation will help us get started with that work. Andy, could we have the next slide, please? Our original plan was that our colleague and Transforming Chaplaincy fellow Marilyn Barnes would be the moderator for today's session, but Marilyn's schedule has changed, and unfortunately, she will not be able to be with us. But participants in today's conversation include LaVera Crawley, Kelsey White, and Christina Shu. LaVera is the Director of Spiritual Care and Clinical Pastoral Education at the California Pacific Medical Center. She is a chaplain educator certified by ACPE. Before becoming a chaplain, LaVera was a physician and a researcher. She holds a master's in public health degree from the University of California, Berkeley. She's completed an ethics fellowship at the Stanford School of Medicine Center for Biomedical Ethics and a palliative care education fellowship at Harvard. LaVera has published a number of articles about racial issues in healthcare, including strategies for culturally effective end-of-life care. References for several of LaVera's publications will be at the end of the slides for today's presentation. Kelsey White is a PhD candidate in the Department of Health Management and System Sciences at the School of Public Health and Information Sciences at the University of Louisville. Kelsey is a board certified chaplain and a former Transforming Chaplaincy Research Fellow. And also joining us is Christina Shu, who's the lead interfaith chaplain at Cedars-Sinai Medical Center in Los Angeles. Christina is the co-convener of the Transforming Chaplaincy Chaplaincy Functions Network, and Christina will be helping today in moderating your questions during the Q&A. Andy, let's look at the next slide. So the plan for today is to kind of take this in 4 different chunks. I'm going to use the next 10 minutes to review those 4 studies that I mentioned. After that, LaVera and Kelsey will provide some interpretation and evaluation of the existing research, and then we'll switch and we'll talk a little bit about where do we need to be going in the future for research about racial disparities in spiritual care. And then we hope that we've left about 15 minutes at the end here for the Q&A. And so that will be our plan for the session. Andy, let's look at the next slide. So as I said, we're going to talk, I'm going to talk briefly about the existing evidence about racial differences in spiritual care. There are 4 different studies that we'll be looking at. One of the studies, the one we're looking at now, addresses the question of who requests chaplaincy care, and then we'll look at 3 different studies about who receives chaplaincy care. It's very important to note as we begin looking at the existing evidence that none of the 4 studies that we're looking at was designed to address the question about racial differences in spiritual care. But each of the studies did contain evidence that allows us to look at that. So here's the first one, racial differences in who requests chaplaincy care. This comes from a study that my colleagues and I at Rush conducted. We actually collected the data in 1993. How many years ago was that? 27? It was a long time ago. We published it about 20 years ago. And part of what we did is we went to patients on several medical surgical units, and we eventually talked to 200 medical surgical patients, and we asked them, would you like to talk with a chaplain? Would you like a chaplain to come and pray with you? Would you like to receive the sacrament of communion? And then we looked at what proportion of patients wanted spiritual care. Overall, the proportion of patients who wanted spiritual care was about 1/3, and a number of factors were associated with being more likely to want spiritual care. And one of the factors that was associated with being more likely to request spiritual care was race. The non-white patients in the study were more likely to be interested in receiving spiritual care, requesting spiritual care, than the white patients. And you can see the proportion among patients who had any of the 3 requests. 27% of the white patients were interested in receiving spiritual care, and 44% of the non-white patients were interested in receiving spiritual care. And this difference was statistically significant. So in terms of requests, there's a greater likelihood that non-white patients are interested in receiving spiritual care. Let's look at the second topic. And the second topic is who receives spiritual care. We're going to look at 3 different studies that have evidence about who receives spiritual care, but I want to show you the kind of bottom line. The bottom line is that in all 3 studies, a greater proportion of Black patients, non-white patients, were receiving spiritual care compared to white patients. So let's get into the weeds, which is the next slide. So the 3 different studies from which we get this data include the study of chaplain care and patient satisfaction that was conducted by Deb Marin and her colleagues at Mount Sinai. It includes another study of chaplain care and patient satisfaction from Annalika Dahmen and our colleagues at Rush that was published in the spring of this year. And the third study is a study from colleagues at Ohio State University in which they looked at a large body of data about among patients who had a cancer diagnosis, who had had spiritual care. So the first two studies, you need to remember, the data comes from studies that were examining spiritual care and patient satisfaction. And the inclusion criteria to have been included in that study was that you had to have returned a satisfaction survey, right? You see the dates in which the data were collected in these three studies. You see a row there that tells you the total sample. The smallest study was from Mount Sinai. There were 9,000 patients in that study. And at Rush and Ohio State, the samples were even larger. You see the proportion of Black patients or non-white patients in each of those studies. So there are substantial numbers of Black non-white patients in all three of those studies. Then you see a row that says, what in the total sample, what's the proportion of patients who had any spiritual care? So at Mount Sinai, it was 5.5%. At Rush, it happened to be 26.5%. And at Ohio State, it was 36%. So then here's the takeaway, right? Of all the patients, of all the white patients in the study, what proportion had spiritual care? And you see those numbers for each of the three studies. And of all the Black or non-white patients in the studies, what proportion had spiritual care? And you'll see that it's higher in each of the three studies. 5% of the white patients at Mount Sinai had any chaplain care, 7.5% of the Black patients at Mount Sinai. 24% of the white patients at Rush had any spiritual care, and 31% of the non-white patients had spiritual care. 36% of the white patients with cancer at Ohio State had any spiritual care, and 40% of the Black patients. And for the comparison of race, for the examination of whether or not the race difference in each study was statistically significant, the answer is yes. In all three cases, these differences are statistically significant. In the Ohio State study, but not Mount Sinai or Rush, they then did an analysis of a multivariable analysis of factors that were associated with who received spiritual care. So that means, in addition to looking at the relationship between race and receiving spiritual care, they looked at other demographic factors, including age and gender. They looked at the relationship between religious affiliation and receiving spiritual care, type of cancer, cancer diagnosis, and having a DNR order, yes or no. And so that's a multivariable model that is examining all of those different factors simultaneously as predictors of who receives spiritual care. And in the multivariable model from Ohio State, race is no longer a statistically significant predictor of who receives spiritual care. That tells us that one of those other factors in that multivariable, one or more of those other factors in that multivariable model are probably contributing to the racial difference, the statistical significance of the racial differences in who receives spiritual care. It could be that African American patients were more seriously ill, they had more advanced cancer at the time of their admission, and because chaplains were more likely to be seeing patients with more advanced illness, they were also more likely to be seeing African American patients. It may be that there were more women among the African American sample, and because chaplains were more likely to be seeing the women, they were more likely to be seeing African American patients as well. So in the bivariate model at Ohio State, there is a statistically significant difference between in the race about who's receiving spiritual care, but in the multivariable model, it's no longer statistically significant. So let's look again, Andy, at the graph, the next slide. Just a reminder, this is kind of the summary, that when we look at these three studies, there is a higher proportion of Black patients who are receiving any chaplaincy care compared to white patients. So that's the existing research. What does it tell us? What are its strengths? What are its weaknesses? What doesn't it tell us? We're going to turn this over to LaVera first, and then Kelsey. Andy, let's look at the next slide. What are the strengths and weaknesses of this research? What do we want to take away from it? LaVera, we're going to turn it over to you.
George. So I want to start with just sort of summarizing with this idea of statistical significance. In my public health degree in biostats and epi courses, I can remember my instructors constantly saying, just because you find something is statistically significant doesn't necessarily mean it's meaningful. So what we want to do here is to look at those that did have some statistical significance and then unpack what meaning can we make out of that. I think we're going to find that there's some meaning, but probably the meaning is more of what is it pointing us to in that next bullet point that we should actually be unpacking to really understand them. But in and of themselves, the meanings, there's not a lot there in these sort of simple descriptive statistics. I want to start with first the first study that asked the question of who requests it, which I was very intrigued with, because as a director of spiritual care, having to set priorities for who needs to go get seen, what units do I need to cover, and particularly in this pandemic where the numbers have gone up, and sometimes my staff goes down for various reasons, and so having to make those kind of decisions are really important. What that showed me, though, is even though it says that there were some Black-white differences, with Blacks requesting it more, I don't know why that is. And so that leaves me to wonder, is there something in the system? Is there something in the individual? Is there something in the spiritual care chaplain or the department or that sort of thing? And I have to begin to look now at those second sets of studies and then who received it and see if that can offer us any additional evidence. So I'll start with the Mount Sinai study. Maybe if it just as a visual, Andy, if it's possible to just to go back to, no, not that one, the next, the one that just has the graph, the bar graphs, yeah. So take a look at the Mount Sinai study. One of the things about that was sort of difficult to reconcile is that there was a very small number of patients in general who even got spiritual care. So we have to kind of hold that in mind as we're trying to make meaning of those who did to get that. I mean, there was like 95% of patients in that study never even got spiritual care. So bear that in mind as we try to make meaning. And then it becomes a question, well, then what were the referral sources? The study mentioned that chaplain rounds were the primary source of referrals. And then secondly, nurses. And then the larger literature tends to say that nurses are really our primary referral source. So what do you make out of the fact that there's a Black-white difference if it's a bit of chaplain rounds or nurse referrals? And when we get to the second conversation about future studies, I want to come back to that point. But that's the question it raises. So what is it about the referrals that might have given us that very slight difference, statistically significant, but 8% versus 5%, I don't know how meaningful that actually is. So then the second study, the second Rush study, same thing, difference, white-Black difference. But one of the things that it showed was that race was not necessarily a modifier in the satisfaction part. Now remember, that study is only, it has that descriptive statistic which we're seeing there in that graph, but then the study was really designed to look at satisfaction. So unfortunately, trying to make any meaning of that difference, when you then go to look at, did it have an impact on satisfaction? It didn't seem to be a strong modifier. And we found that the same thing in the Ohio State study as well. Again, for the descriptive statistics, there seems to be a slight difference in who gets it, Blacks versus whites. But this study was designed to, again, to look at satisfaction. Not satisfaction, it was designed to look at the impact of that. And it showed that the odds of getting a chaplain visit was not really based on race. And that's what George just said. I'm saying it in another way. In other words, that comparing the whites and the Blacks, the odds of getting a pastoral visit didn't vary by race. So these leave us with many more questions than they do give us answers. And I think when we get to the part that we talk about the different research that we can do as a result of these, I'll expound on that a little bit more. But I think my 5 minutes are up, so I'm going to hand it over now to Kelsey and to see what brilliance she adds to this. So.
Thanks, LaVera. So for me, when I kind of go back to the original questions, are there disparities? Are there differences between who receives spiritual care and who doesn't? I take myself back to the original context in which those conversations are happening. So oftentimes we hear this word disparities, I think, in healthcare and social determinants of health and those kind of hot button topics and words that are at times kind of tossed around in a casual sense. But really what's at the root of it is that there are communities and people who receive health services, and a lot of communities and people who don't receive the health services that they need. So a lot of that is related to underrepresented communities of racial or ethnic identity. And in health services research, what happened when we talk about the passage of the Affordable Care Act is that we, as a country and as a collection of healthcare systems, we reduced racial and ethnic disparities through increasing the affordability of healthcare by covering insurance, right? This is all a long side note to get to where I'm going in terms of spiritual care, but trust me. And what researchers noted is that through increased coverage and being able to afford coverage, those that were uninsured and underrepresented communities, those that forewent medical care, the proportion of those folks in those communities decreased. And so more people were using care, right? Even the Latinx community actually experienced greater increase in coverage and utilization of care. And so really, if we're talking about addressing disparities, or if they're addressing, before we can even do that, we have to know who's using it. And the OSU study is really the only study that talks about who is using spiritual care, and that's limited to an oncology setting. Even then, the biggest challenge that we note in disparities in access is that we assume with all of these studies, because of their context, because they're in healthcare systems, is that people already have access and entry into a point of healthcare delivery. So let me say that again. These folks already have entry into the point of healthcare delivery. So they're already at an increased likelihood of receiving chaplaincy care. And as LaVera noted, as George noted, there are tons of things we still don't know. Were a lot of these visits done for referrals? What inside of the referral? What types of tension, what types of social cultural dynamics were going on in that community that may have increased fear or brought those bias levels to the forefront for different actions, or prejudice was increased for a specific reason? We don't know. So what these snippets of data really show us, to me, is that within a point of delivery, like, we can't talk about disparities in spiritual care until we can start talking about the provision of spiritual care to more at all points of healthcare delivery, outpatient, public health delivery services. All of those points can we talk about when we can study the utilization there. And again, we have to study who uses it, and then even further, what we may be missing in terms of, is it the care that's needed? Of course, this is now getting into what does the future research need to look like, right? Because really, we know more about what that needs to look like than what these studies tell us. But I think what's important is to know that just that we are looking at utilization, that these 3 studies are able to really talk about who uses it, but not intentionally, and only OSU can talk about that intentionally. This is who used it, but we still don't know why they used it. And so with that, I'll stop and let LaVera jump on the bandwagon of what we need to study next.
That was a great baton you just handed me, because I want to start with the idea of differences versus disparities. So we've seen that there are some differences from these studies, but are they differences that make a difference? So to me, there are a variety of things that we can use to think about what really makes a difference. And one of the first earlier slides that was just setting the stage was about racial disparities. So the question that Kelsey is asking us to consider is, do these differences rise to the level of being disparities? So disparities, I'm going to make it really clear what difference that makes. Disparities are those kinds of differences for which things are unfair. They are inequitable. And there are things, therefore, that we really should be paying attention to try to do something about. So I raised that one of the questions that came up for me in some of these studies was, all right, well, let's look at who is doing the referring. In the one of the Rush studies, it was a statement that chaplains were the primary source of referrals. So what is it within the chaplains that might account for this Black-white difference? And what is it if it's nurses? What is it about nurses? Are there and the fact that though the really contradictory thing that let me just say, I would love to sit in a room with many of you, but certainly all the panelists and George, and just sit and ponder that question to make it a beautiful question, as Warren Berger writes about beautiful questions, that we could start piecing out. All right, so on the one hand, this paradox, on the one hand, well, Blacks are getting more, but is there some sort of bias that, oh, well, all Blacks really probably want this because there's a stereotype that all Blacks are very religious? I don't want to speak for the chaplains as referral, because as I mentioned, as a referral source, because I mentioned that the literature says nurses. So let's just for a moment look at nurses and other providers who are the sources of our seeing patients. Is it because they are uncomfortable dealing with Black patients that they're saying, let's go call the chaplain to go handle that? So that would be sort of an inequitable reason to do that, even though the outcome is that Blacks would get more spiritual care. But I want to look at the primary driver for that. Is there some basis of racism? Is there something about the system in that healthcare, in any given healthcare, that might then say, we had a lovely brief conversation, the panelists yesterday, and I raised the example of code grays. And we know that code grays tend to be called more often on minority Black patients, minorities and particularly Black patients.
LaVera, let me just interrupt and ask you to explain code gray, because not every institution may use that phrase.
Thank you. So it's when there is the need to call for security because of an escalated encounter with a patient. So anger, and it can escalate all to be physically violent. And so at the first signs of that, many hospitals will have a code that they will call so that security comes and rushes. And I know that in our facility, we also ask our chaplains to go there too, mainly because chaplains can be that de-escalating energy in that encounter. But back to, the pattern is that there are more Blacks who are called for that, for a code gray, or for this need for violent de-escalation of potential violence or violence in actually happening. So is this, that kind of sort of factor that people are just a little skittish about Black folks, and so they'll just call for the chaplain to come handle it. We don't know that. And that's what the limits of just these first studies, but the intriguing limits, because they ask us to ponder these kinds of questions. I could go on with lots of other research studies I'd want to do, but just to just summarize, I think that we need to be looking at the potential for disparities at least 3 levels. And one other paper that we've read, as this team here read for preparing for today, and it's listed in the bibliography at the end, was a commentary to ask us to look at that. And I know from my own previous studies, it's important to look at it if there are disparities, unequal treatment at play here. Is it coming from the individual at a personal level, both the individual chaplain? Is it coming from the individual nurse or the individual other provider who's making those referrals or not making the referrals? Or is it at the interpersonal? So an example is, are you just not comfortable talking to a person if they don't share your language? We are trained as chaplains to be interreligious, but are we equally trained to be intercultural, interracial in our encounters with people? So there's another area for research. And then lastly, is it something in the system? And chaplains are in a unique position to be able to identify those systemic inequities and advocate for them. And so all of those are open for us to begin to study. And I'll hand that back over to Kelsey.
It's a lot of questions to answer. I feel like if we had a sandbox in front of us, and I say that because I have a 4-year-old who plays in a sandbox all the time, that I have about a scoop of sand right now of knowledge and of information, which may make, as George said earlier, what we present potentially frustrating because of the limits of what we know, but just think of all of the information we could collect. I think where my brain goes is we really need a much larger utilization study. So thinking multi-state, multi-system, I like big data. So like if I could have, 50 hospitals and 50 systems send me all their utilization, who's using chaplains, who's not using chaplains for a year, racial demographics, religious demographics, the chaplain, how was the chaplain called there? Why was the chaplain called there? What did the chaplain do? Very brief things. I mean, I'm not talking about complicated data. Most people I know are finding a way in terms of chaplaincy departments to record that data. And if 50 systems got together and kind of pulled their data, what could we consider in terms of utilization of chaplains? And then even larger, contextualize those within the counties and the physical locations in which hospitals are situated to consider how the utilization meshes or perhaps doesn't mesh and aligns or doesn't align with the physical location and the typical population that utilizes that hospital. And a lot of the patient experience studies, you'll hear about the case mix adjustment, where studies will adjust for the population of typical users within a hospital. And I think that that's something that needs to be considered too, is, what's going on in the physical place of that hospital. Or if you have multiple hospitals located together, what is happening there? And really, to know more about disparities rather than differences, like LaVera highlighted, is watching these things over time. With these studies, we have simple cross-sectional kind of snippets of what's happening, but what happens over time? Do most patients receive a single visit? But then there's differences once you get to those higher tier, multi-faceted chaplaincy relationships. What happens? So I think there's a lot of different directions we could go. And at the end of the day, we also need to not just know who's using them, and how a institution or a system's resources are related, but also, like, is it doing what it needs to do? But that again goes back to that, like, that quality piece versus do the people who need it have access to it and can use it?
Can I want to add one other layer of our considering, because these are really compelling things to consider in terms of utilization and quality. But I also want to go back to a very simple question of why. You know, why? And I want to quote from Warren Berger, who wrote, you know, several books about questions, how to create beautiful questions. And he defines a beautiful question as an ambitious yet actionable question that can shift the way we think about something and may serve as a catalyst for change. So if we started off with saying, okay, if these differences exist, why? And then before we get into looking at patterns and numbers, if we first start with a really good, robust, qualitative question to really try to understand the experience of the chaplains, of those who refer to us, of the receivers, in terms of the processes that they are exposed to around getting or not getting pastoral care visits. And I think that could then really help inform any of the other quantitative studies. Then it also could also even direct where we should be putting our attention. So.
LaVera, Kelsey, thank you for your thoughts, your conversation about what we know and don't know from the existing research, your thoughts about where we want to go in the next steps with the research. Is this a time, Christina, when we can begin to get into the Q&A from the participants? You look like you've been reading that screen very carefully, and is there anything you want to say? I'm not sure you've been able to listen. You've been reading so much.
Sure. No, I think we can definitely dive into Q&A. There's a lot of really rich questions coming through.
Go ahead, we're in your hands.
Okay, so thank you to everyone who is submitting questions and is continuing to submit questions. I want to start with one of the first ones, which relates to the pandemic. So someone asked if there are any current studies addressing this question happening right now. And I guess I would also maybe broaden that to say, like, knowing what we know about racial disparities in COVID-19 statistics, is there a, you know, what are some questions that we might have, or if you were designing a study right now for a current healthcare climate around, you know, spiritual care and who receives it, what would you want to look at?
LaVera, Kelsey, either one of you want to take a start at that?
I can't address the first part of that question in terms of the current studies, because they're just not at the tip of my, they're not at my fingertips right now. But I am, the public health trained person in me would want to not start the question of looking at these disparities in the hospital. I'd be looking more at the community level, because I think that's, just and making sure I wasn't conflating things like poverty and race, which is often, unfortunately, conflated. But as I go around, I live in Oakland, California, and as I'm going around and looking at the various encampments of the unhoused, and knowing that that is a hotbed of where the virus is spreading, I want to know, I would start my efforts there to look at the how we can stop that process, because the ones we see in the hospital are it's happening out in the community first before we do that. So that's where I would want to put my attention.
I would just say that, I'm not aware of anything in terms of chaplaincy studies regarding utilization of chaplaincy studies in terms of the pandemic at this point. In terms of healthcare system use in general, I think what's most frequently noted is that the pandemic has kind of reinforced the existing struggles and disparities in health outcomes that have already been present in the U.S. And I know that probably doesn't sound surprising to anybody, but that's kind of what I've seen in the research so far, but nothing specifically in terms of chaplaincy. And I like what LaVera said in terms of looking outside of hospitals for future research about that.
Yeah, let me just join in on that. Transforming Chaplaincy is involved in 2 studies around spiritual care in the pandemic. One is interviewing spiritual care managers about how spiritual care has been changing during the pandemic. The other was asking chaplains to keep journals about how their spiritual care, during particularly the spring. But those are not going to get us in a rigorous way at the question of are there racial disparities in the spiritual care being provided to patients and families during the pandemic. So yeah, we need to think about, okay, are there good ways we could get at that? Yeah, Christina, what more?
Well, there have been several questions about, the race of the chaplain or the race of the person making a referral or the interviewers who were asking participants in these studies. From hearing you talk about some of the limitations, it sounds like that wasn't tracked. But again, if you were kind of creating another area of research or another study, can you speak to how that might impact results?
I would love to. So like when Marilyn and I did the mapping chaplaincy workforce paper, where we talked about all the different demographics and characteristics of professional chaplains of the 3 major professional chaplaincy organizations, as well as an ACPE, those that are certified educators, those who are students, those who are certified educator candidates. You know, as we noted that a majority of chaplains were identified as white, and that there was actually this interesting within the certified educator candidate pool, a larger proportion of African American identifying folks and evangelical Protestants, as well as within the student group, that we are interested to see if that changes. And ideally, we had hoped to see if there was any concordance between the educators and those moving into that educator role, or even students moving into chaplaincy, if there was any type of concordance there that would kind of strengthen that relationship or add anything, but the data wasn't really built for that. It would be incredibly interesting to see about demographic or any type of characteristic concordance or discordance between chaplains and the patients that receive their care in the same way, to see what type of is there a specific type of relationship there, whether it be based on religious affiliation or racial ethnic identity or gender identity, that would really help or impact that patient experience differently than otherwise. That would be fascinating study to me. Obviously more complex than easy to pull off at this point, but definitely something that we need to look at and consider.
LaVera, do you have thoughts about that?
I'm not as aware of the studies on race concordance within the spiritual care research literature. I'm more aware of it in the medical literature, and it's a little bit all over the map, because one might say logically that same race concordance could have better outcomes, and some studies do show that. But there are other studies. I can remember one that pops to mind. It was a big study done at UCLA in the emergency room that looked at differences in pain, where there was definite disparity in who got treated adequately in the ER for pain. And then when they looked at the physicians who were the ones not treating patients well or equally, there was no difference between Black, Latino, or white or Asian physicians. The physicians in general just did a bad job, and Black physicians did a bad job around treating pain for Black patients and Latino patients. Latino physicians did as bad a job. So it's a little bit all over the map. And I agree that would be an excellent question to to consider, like, what is the role of race concordance in referral or in the outcomes or quality of outcomes. The commentary that we were asked to read, again, the reference will be down, talked about the value of trust, and that the importance of a patient being able to trust their provider, and in this case, the chaplain provider. And those studies do show that race concordance is a valuable commodity to have to build trust. It isn't the only one. It can sometimes backfire, but it is one to consider. So I think it's a fascinating question, and I appreciate the questioner for posing that to us.
And the interesting thing is too that, you know, those studies that you were talking about with the physicians really mix in the results. And then if you look at the material around education, where you have an educator, whether it be K through 12 or even some college studies that talk about concordance between educator, mentor, and student, it is shown as incredibly beneficial in those studies. So it would be really interesting if you think about the two fields in terms of how chaplaincy intersects with both of those. So go ahead, George. Sorry, I cut you off.
No, yeah, so let me just kind of say exactly right. It'd be a great study to do. We don't have any studies about the impact of concordance, chaplain concordance with patient or family around race, around gender, around religious affiliation. All of that actually is important areas for future work. LaVera has mentioned a few times a paper that was in the journal Pastoral Care and Counseling by Joe Bradley, who's a chaplain in Southern Indiana. And that paper is in our references. We'll see it in a minute. So you'll be able to look that up if you're interested. Joe's offering recommendations about skills and knowledge for white chaplains who are working with African-American patients and families. And we thought it was a very thoughtful contribution to the literature. Christina, what else?
Yeah. So just a reminder, this is being recorded, and the whole presentation will be made available to everyone after. So if you didn't catch every reference, or you're interested in the resources that we have at the end of these slides, that will be all available. Really, there's so many interesting questions, so I apologize if I'm sort of summarizing or combining your question and not reading it directly. There have been some questions that ask about, you know, how you deal with other factors, not just race, but, you know, that there's a lot of differences even within white or Black groups, and we didn't even talk about other racial or ethnic groups. Also, how we deal with social class, income, regions or geographic distance from the hospital. And I know in our pre-panel talk, we also talked about language and speaking a language other than English. So maybe you could talk about how those factors might also affect our topic.
Yes, they do. I mean, I think well, we don't know. At the end of the day, I think they're all important things and all things that we need to examine further and put intentional effort into including into, you know, whether it be a qualitative or a quantitative type study, because they are all things that have been shown to impact how and why people utilize healthcare. And so one could assume or think about that would ultimately also influence the utilization of professional spiritual care.
Yeah, when you're starting to think about the issues of intersectionality, it's like one patient then represents a bunch of different variables, right. But yet when we do simple bivariate analysis, we're not really taking those things into consideration. You get a little bit better, in fact, quite a lot better when you begin to do some of the multivariate studies, but even still, you're still looking at individual variables and seeing their impact and seeing you know, are there some that are modifying? One of the studies that showed that difference, that bivariate difference in black and white, but then the multivariate analysis showed nothing, then started hinting at this intersectionality piece that, okay, maybe it wasn't the fact that someone was black, maybe it was, you know, this factor or that factor. So we really do need to have really robust multivariate studies with a fair amount of sophistication in trying to ask the big question why when we're seeing these things.
Well,
yeah,
and
I
when
mean,
we go ahead.
No, well, yeah, go ahead.
I was just going to say, and when we talk about spiritual care as part of that, there is some unmeasurable element to it all, which makes it even more complex. So even if you do have a very sophisticated multivariate type study, we can't ever fully assume that we can predict it all, that we're going to have some omitted variables in what we do. And that is just the limitations in general of a lot of the statistical approaches. Although I think we could get a lot closer than having one scoop of sand, personally.
And I think what you're pointing out is the value of a mixed methods study.
Right.
Because for those, you know, for the numbers and the quantoids out there, yeah, that would help give us, but then we need to ask the why, the beautiful question of why, and then have that, the qualitative piece, then inform the next iteration of the quantitative piece. And, you know, for those in academia, those are multiple grants that you could go for, and certainly multiple papers for your, you know, rising up the ladder, the academic ladder. But yeah, that's really what's needed.
Christina, I think we're going to probably have time for 2, maybe 3, if we're quick in our responses.
Okay. So I guess I wanted to ask about something that you've touched on, which is kind of training for chaplains in anti-racism, or what some people might call cultural competency or cultural humility training. And also, I think that might impact the question of, are we going to studies of outcomes for chaplains with patients? And if a chaplain who has had this type of training, or maybe also matches the identity in some way of a patient, has an impact on a certain outcome we're studying, whether it is, you know, maybe de-escalating from a violent situation, as LaVera mentioned in Code Grays, or it's a better sense of well-being for someone who might be otherwise marginalized in our healthcare system. There have been several questions about just generally, like, what do we know about outcomes? And, you know, kind of to LaVera's question, what is our why? You know, is there a question about outcomes that we want to look at that might kind of trace back to what we want to do in terms of training and resources for chaplains?
Well, there's a lot that's out there that in recently, really because of the pandemic, and as George's opening remarks were pointing out, the past year with the murder of George Floyd, and the new or renewed awareness of racial disparities that are out there, certainly have called into question, are we doing enough in our training? And as an ACP educator, I mean, we already have outcomes that we expect from CPE students to address their capacity to work across differences. And are we doing enough? I would say that there's a lot of attention being paid to this now, and I think that if I was trying to be expedient with a group of new students, CPE students, chaplaincy students, and I wanted to just cover a wide swath of these very issues, and not just, as that previous question was about, not just narrowing it to, can you be more racially? I would racially competent. I would start with issues of really exploring trust and trustworthiness, and flipping it as, how can I get patients to trust me? Because trust is a really key factor in all kinds of healthcare, but we're talking about spiritual caregiving. Instead of saying, can I get the patient to trust me, which is putting the onus on the patient to do the work, to trust me? Can we start looking at my trustworthiness and what are the various aspects of who I am as a provider that could help someone perceive me as someone they can trust? I think that's a more generic piece, and we can get into the fine details of cultural competence around different groups. And in my CPE program, we do, care of the African American patient. We look specifically at what does death mean if you are a particular ethnic or cultural group, and what are the, what do we need to know to be able to understand that person's worldview, their experiences. And so that's important. But again, I'll just go back to what I said at the beginning. I think if I had to be the most expedient thing I wanted people to learn is, what do I need to do to be trustworthy across the board? So that's my starting place.
Kelsey, you want to add anything, or we're going to let Christina get one more question in? Christina, I think it's going to be one of the last ones here.
Okay. Well, I really liked that idea of trustworthiness. Okay, new question. This is a great one. How is trust and trustworthiness connected to accountability? Accountability is something we haven't talked about. Like, who are, I might say, I'm not sure what the questioner means, but who are chaplains accountable to? And, what does the value of racial equity have to do with that?
I've been jumping out of the gate first for most of this, so I have a response, but I'm curious what others might want to do.
Go ahead.
Well, let me go back to the example of Code Gray and the fact that there's a pattern that shows that there are more Code Grays. That's that need for security to come and de-escalate a situation more often for Black and other minority patients compared to whites. And then now let's place the chaplain in that situation. And I'm just really pulling from my own personal experience once trying to de-escalate a situation. And racially concordant, so the patient was Black, I'm Black, and going into that situation and wanting the person to see me as an ally, the patient to be seen as an ally, yet I'm wearing a badge that says that I represent the hospital. And it's despite my best efforts and I hadn't known this patient. I didn't have a prior relationship with this patient. So it was sort of a first time coming in. And just assuming that maybe he sees a Black face, he's going to feel a little bit more comfortable. But what that person saw was, this is an individual who's accountable to the hospital system. So again, I'm not, like Chelsea, like Christina said, I'm just not quite sure what the questioner means about accountability. But what came to me is, we have to recognize that we have multiple conflicts of interest. And one of the facets of trustworthiness is, are you able to put the patient's best interest above any other conflicts that we have? And so the task at hand is to try to do that genuinely, and recognizing that we are also accountable to the hospital system. It's a quandary. I don't have an answer, but that's what gets raised for me, that I need to do something. If I want the patient to trust me, I need to do something that shows I'm putting that person's interest first, best interest first. Yeah.
Kelsey, you want to add anything?
I think that's well said.
It is well said. It's all been well said. I'm going to move toward wrapping up here. Andy, why don't we just go through the slides here and get to the last one about so the studies that the 4 studies, the references were there. Here's some other resources. The article by Joe Bradley we've been talking about. Our colleagues at NACC and their Vision magazine have recently had some material about racism. Those of you who are in ACPE know that ACPE has been doing a series of webinars called the 846 webinar series around trying to provide resources for CPE educators. And the next slide is LaVera's references. and not. This is not all that LaVera has published. She was hard at work for many years around that palliative care and issues, but here's just two important places to get a feel for LaVera's good work. And then finally, we're going to let you know that for those of you who find the webinars helpful, we have a webinar 2 weeks from today, actually, and the webinar 2 weeks from today will be devoted specifically to the Ohio State University study that we've been talking a little bit about, but we'll get into the details about how to use big data, right? It was 14,000 patients. How do we use big data to help us understand what spiritual care, who's getting spiritual care, and what kind of spiritual care they're getting? So that'll be our last webinar for 2020, and then we're going to kick off 2021 with 2 webinars. You can see there early January, Tim Ussett and Irene Harris will be with us to talk about psychospiritual development in patient care, and specifically psychospiritual development in veterans and its association with moral injury. But we think thinking about psychospiritual development is an important pathway into deeper understandings of our patients and more effective spiritual care. And then some of you know that there are some important developments around chaplaincy documentation, and we're going to be having several webinars about that in the first half of first quarter of 2021. But we'll start with a webinar in which our Swiss colleagues who've put together this book on international global perspectives on chaplaincy charting and documentation, Simon Penkeller and his colleagues, will talk with them about their new book. So we hope you'll join us for those webinars. Thanks for joining us today. Many, many thanks to LaVera and Kelsey and Christina for your participation and your thoughts and your insights in today's webinar. Friends, just a kind of reminder, as we said at the beginning, this is the beginning of a conversation. What does it mean to take a deeper, closer look at the spiritual care we're providing, to look at how race affects that care, to look at whether or not we're providing the best care possible, or whether or not we can do, there are ways that we can improve the care that we provide for African American patients, Latinx patients, other racial minority patients. And so how can we use research to strengthen and improve the care we're providing? That's our commitment to transforming chaplaincy, and we look forward to working on that with you. The kind of research we've described today is not going to be easy. It'll take a lot of resources. It'll take hard work from teams of qualified and skilled people. If you know a donor who's looking for a place to make an investment in improving spiritual care before the year is over, please let us know, because this research is going to require resources as well. Andy, thanks for all your help. Friends, thanks a lot. Have a good rest of your day. Bye-bye. I think we're in a private session. Andy, are we in a private session?
I just ended the, you want to end the webinar? I think it's going to end.
Yeah, good. Thanks, friends. Comments, questions, thoughts? Really appreciated everybody's jumping in there, being part of the conversation.